dose should be less than 2. So it showed that the whole heart mean heart dose was less than 2.5, and in left ventricle, the D mean was D mean of left ventricle should be less than 3 gray, whereas for left anterior descending artery, the D mean should be less than 10 gray. So this was the DGRO breast cancer panel recommendation based on different techniques, that this is the constraint that should be given to heart, the left ventricle, and left anterior descending artery. Now, how to reduce this cardiac and lung doses? So, techniques to reduce doses to the OARs. We have seen in patients who have bulky breast, if they are planned in a prone position, so it allows for good breast and lymph nodal coverage with better sparing of ipsilateral lung, contralateral breast, and contralateral lung. So it showed, as we can see in the figure A, when the patient is supine, when we are giving the medial and lateral tangential beam, it is including 1/3, almost around 20% of the heart with the beam. But when it is done in a, because it is a bulky patient, so the lateral margin would be more. So, but when the same patient is taken in a prone position with the breast hanging, the medial and the lateral tangential, it is going, and it is including very minimal of heart. So it was seen with this in prone position, less infield heart volume was observed as compared to supine position. So this is one of the technique. If the patient has yeah, pedunculated breast, then the patient can be treated in prone position. Next technique, it was seen over the time from 1970 to 2006 that the heart dose gradually decreased. In 1970s and 1990s, there was not, and there were no CT-based planning. So what they did was they took the original beams, the beams that were given in the 2D era, and they drew it virtually on a CT-based planning. And that showed that the heart dose in such patients in the 1970s and 1990s, the D mean was around 13.3 and 4.7, which in 2006 was reduced to 2.3. And why was this? It was observed that the factors contributed to this reduction in dose included the shift of the medial field border. So the medial tangential, the medial tangential beam was shifted. So it would spare the heart, and it would include the internal memory lymph nodes. And with the use of higher energy beams rather than cobalt, there was better doses to the breast and less to the heart. And again, then there was CT data for RT planning. So these three factors, when seen through time, it caused reduction in the cardiac dose. Now, with the use of advanced technique, we have seen there was a study by Dogan et al. In which IMRT was compared to the 3D CRT, conventional biowedges, and it was seen that doses to the heart, left lung, to the ipsilateral lung, and contralateral breast had significantly reduced with IMRT technique as compared to the 3D CRT. So it showed that IMRT improves breast and regional nodal coverage while decreasing doses to the lung, heart, and contralateral breast. When comparing toxicity in terms of skin, there were studies done, and one such study was by Pignol et al., in which IMRT therapy was seen to reduce the acute radiation dermatitis. In these patients, patients were randomized into 2 arms with standard RT, which was tangential, and the other was the IMRT arm. So it was seen that the moist desquamation in breast and mostly in the inframammary crease was significantly lower in the IMRT technique as compared to the standardized RT arm. And the conclusion was that the breast IMRT significantly reduced the presence of moist desquamation compared with standard wedge technique. Another trial was by Barnett et al. And this was a randomized control trial, and the interim result at 2 years showed that the telangiectasia was similarly lower in the IMRT arm as compared to the uh, um, um, uh, control arm. So the IMRT led to significant reduction in telangiectasia at early follow-up of only 2 years after RT completion. And this same trial, after the 5-year result, it was published. It was published by Mukesh et al. And the trial it showed that on univariate as well as multivariate analysis, the skin telangiectasia was significantly lower in the IMRT arm as compared to the 3D CRT arm. So the skin toxicities had reduced with IMRT, and the overall cosmosis was also better in the IMRT. So the benefit of IMRT was maintained on multivariate as well as univariate analysis. Now, after the IMRT arm, there came hybrid IMRT plans. This was a study by Mayo et al., in which, apart from the skin, it was seen that the doses to the lung and heart also reduced with the IMRT technique. So in this, they had compared patients with 5 techniques: tangential, field-in-field, IMRT, and 4 and 6 field hybrid IMRTs. So in this, they had observed that the mean PTV coverage by all the techniques were similar, but the doses to the lung, P20 of the lung, was significantly lower in the IMRT technique, and the V5 and V30 of the heart was very low, was almost zero. But if these were patients with the left breast cancer, so the doses V5 and V30 with field-in-field and IMRT was lowest. So with IMRT, again, it was shown that the doses to heart and lung were subsequently reduced. After this came the VMAT technique. So the VMAT technique, it was shown that if the patients who were included, who were given regional nodal irradiation, and they included the internal mammary, supraclavicular and axillary lymph node, it showed that the regional nodal irradiation was associated with a marked increase in heart and lung doses. So with regional nodal irradiation, there was more dose going to the heart and lung, particularly when the internal mammary lymph nodes were treated. And the advantage of VMAT and IMRT for breast or chest wall was associated with moderately increased lung dose. So with VMAT, they were able to spare the heart, but the dose to the lung was increased in such patients. Then there was partial breast irradiation. Many studies were done for the partial breast irradiation, and all of these concluded that the 5-year overall survival was similar in both of these arms when the patient was given whole breast irradiation as compared to the partial breast irradiation. But partial breast irradiation, it presented with better results in terms of acute and late side effects and the cosmetic outcome. So partial breast irradiation, although a particular subset of patients can only be given, but they had better side effect profile as compared to whole breast irradiation. Now the techniques to reduce respiratory movement. So we know one of the challenges we face while treating a patient of carcinoma left breast is inclusion of the heart and lung within the near to the planning target volume. So so there was DIBH that came into play, which showed that reducing the distance, increasing the distance from the chest wall from the heart, it showed to reduce the dose to the lung and heart. So in this study, they compared 5 patients, 5 techniques, in which DIBH was shown to reduce heart and lung doses when deep tangent were used for left breast irradiation, including the internal mammary lymph nodes, compared with the shallow tangent along with electrons. The deep tangent with DIBH reduced the heart dose and resulted in comparable lung toxicity. So in this study, they compared DIBH, and one of the arm had shallow tangent with electrons also. And it showed that deep tangent with DIBH reduced the heart dose and had a better lung toxicity parameters. So left-sided, this was again a study showing DIBH, and in this, it was shown that the patients who were uh, evaluated on both the stands, free breathing as well as deep inspiration breath hold. In this, the IMRT patients, they did better as compared to 3D CRT. So in terms of heart mean dose, left anterior descending artery mean dose, and V20 lung all had significant value when DIBH with IMRT was compared with DIBH with free breathing. So, DIBH with 3D CRT. So IMRT resulted in significant additional decrease of dose in heart and left anterior descending artery region in both breath hold and free breathing. There were many trials which compared DIBH with the standard technique, and all concluded that DIBH is a reproducible and stable technique for left breast irradiation, showing significant promise in reducing late cardiac toxicities associated with radiation therapy. Then after this, there came proton therapy. So this was a trial done by Ellis et al., in which they had three scenarios. In the first scenario, they compared 3D CRT with IMRT with intensity modulated proton therapy in whole breast only. And they showed that the V20 of lung significantly reduced when comparing 3D CRT to IMRT to proton. So it was least in the proton. And the heart mean dose was again least in the proton arm. Now, when whole breast along with medial and lateral supraclavicular lymph nodes and axillary lymph nodes were included, the three arms again showed better V20. It was least in the proton arm, and the heart mean dose was again minimum in the proton arm. And when internal memory chain was also included, it again showed that the V20 was minimum in the proton, and mean heart dose was also minimum. The benefit of intensity modulated proton therapy is based on improved target coverage and reduction of doses to the OARs, potentially reducing the risk of late toxicity. Now, these were the trials that have been published worldwide, and our institutional experience based on that, we follow certain guidelines. So in our institute, where we give primary dose to the primary and regional irradiation, we follow a hypofractionation regime, quoting the Canadian trial, in which 42.5 grain 16 fraction is given. And if boost is given, it is given in 10 grain 4 fractions. And the recommendations are that the PTV whole breast or chest wall should be dose receiving 95%, dose receiving 95% should be more than dose should be more than 95% of the PTV should be receiving 95% of the prescribed dose, and D90 should be more than 90%. And when boost PTV is included, then D100 should be more than 95%, and D105 should be less than 5 to 10% within PTV, and it should be less than 150 cc outside the PTV. So this constraint of less than 150 cc outside PTV, this is to see the plant quality, whether if it is less than 150 cc, then that means the quality of the plan is good. And if it is more than 150 cc, then even though the rest of the constraints are being met, the plan is not so good in quality. Those receiving 110% should be ideally 0, and those receiving 95% should be less than 1% within the PTV. For OARs, ipsilateral lung volume receiving 20 gray should be less than 30%, and for right-sided breast cancer, D mean heart should be less than 2 gray. For left-sided breast cancer with DIBH, the D mean should be less than 4 gray, and left side without DIBH, D mean of heart should be less than 6, but it can go up to 8. Also, the heart volume receiving 25 gray should be less than 10%. For contralateral breast, D mean should be less than 4 to 5 gray. So these are the our institution dose constraints that we achieve for treating the patients. Now I have with me some uh, patients on whom we have made certain plans. So I'll be discussing patients both with the whole breast radiation and with post mastectomy radiotherapy with and without DIVH. So this first patient, this is a patient with the whole breast RT given regional nodal irradiation without DIVH. In this patient, we had made 5 plans. First is the tangential plan. Second is the tangent with wedges. Third is the field in field. Fourth is the IMRT arm. And fifth is the VMAT. So in these patients, it was shown that the dose first with the tangent, there was high dose on the skin surface, which we can see is around 52.69 gray. When wedges are used, the skin dose, the hotspot over the skin, they go towards the inner side. So the dose to the skin, it decreases from 52.69 to 48.92. But now there is more homogeneous dose beneath it. With field in field, the dose has further reduced and there is more homogeneous dose distribution along the PTV. Whereas with IMRT, the homogeneity is more, and with VMAT, it is the homogeneity is at its best when we can see this plan. And when evaluating, it was seen that V20 of lung and D mean of heart, it was significantly lower in all these 3 plans, which was field in field, IMRT, and VMAT technique. With IMRT, V20 lung being the minimum, around 29.40, and D mean of heart being the minimum. But the dose to the contralateral breast was more with IMRT and VMAT technique, as we have seen in the studies which we had discussed previously. So with whole breast RT given regional nodal irradiation without DIVH, field in field, IMRT, and VMAT, all these 3 techniques are much better than conformal or wedges with or tangential with wedges.
DIBSটা কি শুনে যাচ্ছে?
Please mute others. Okay, please continue.
Okay. So as I was saying, with when the patients with whole breast RT giving regional nodal irradiation without DIVH, all these 3 plans, field in field, IMRT, and VMAT, they showed significantly lower doses to the lung as well as heart. But with IMRT and VMAT, the doses to the contralateral breast had increased. When in the same patient we compared free breathing versus DIVH, and the plans were made, it showed significantly lower doses in the DIVH arm, which had reduced from 29% to 24%, and D mean of heart from 5.15 to 4.20. So we made 5 plans in this patient, but with DIVH. So whole breast RT with regional irradiation in DIVH. So we had again made 5 plans, tangential with wedges, field in field, IMRT, and VMAT. So this is the dose covering 95%. This is 95% coverage we're seeing. So it is more homogeneous in the field in field, IMRT, and VMAT technique. And this is the hotspot which we are seeing. It is more towards the surface in the tangential arm. It goes a little inside when used with wedges, more uniformity. With field in field, it is overall distributed, and with IMRT and VMAT, there is no hotspot. So now, when we compared this patient, whole breast RT with and without DIVH, it was seen that the field in field, IMRT, and VMAT technique had better side toxicity profile in terms of lung and heart, which showed that the lung had significantly reduced doses with DIVH as well as heart, and the contralateral breast was also less, but it was field in field, which was overall best in terms of low dose to the lung and heart as well as the contralateral breast. So in our institute, we follow field in field with DIBH for patients for all the left side, left breast cancer patients. For right-sided, we can we have an option of field in field or IMRT, and in some patients we do VMAT also. But our main technique for treating a patient of carcinoma left breast is field in field with DIBH. This is a post-mastectomy radiotherapy patient in which renal node irradiation with DIBH was done. And in this, again, 5 plans were made. First with tangential, second tangent with wedges, third field in field, fourth IMRT, and fifth VMAT. This is the hotspot again, showing more towards the skin surface in the tangential arm. It is more distributed when used with wedges, and it is less in the field in field, and then there are no hotspots in the IMRT and VMAT arm. So in this patient also, the V20 of lung and D mean of heart was less in these 3 arms, field in field, IMRT, and VMAT, and the dose to the contralateral breast was higher in the IMRT and VMAT arm. So in such patients also, we do field in field in post-mastectomy patients. But then again, our institutional protocol is field in field with DIBH in all such patients. Thank you.
না উপরে ইসলাম ফাহমুজ্জামান স্যারের ওখানে একটা রোগীর সাহায্য করার জন্য স্যারের মাথা এখন হেভি গরম অবস্থা।
Please,
Dr. Rubina.
okay, thank you very much, Sandeep.
Yes, sir.
So can you stop your slide share? Okay.
Yes.
So thank you very much. I think it was fairly covered. You have tried to cover almost everything. There is a question already. If DIBH is not available, which technique is preferred for left breast irradiation? You can cover,
Yes,
and
sir.
I will bring up, pull out what of the question that I was keeping for sharing with you. So let us start with this question. If no DIBH,
Yes, sir.
for left-sided breast, what is
So if there is no DIBH technique available, and so we have to include all the lymph nodes also, right?
Yep.
So for such patients, so we have seen that field in field and IMRT both techniques are applicable in such patients. IMRT is better in terms of if the doses to lung and heart are being evaluated, then IMRT is obviously better as compared to IMRT and as compared to field in field and or VMAT. But the only problem with the IMRT is that the doses to the contralateral breast, it is somewhat larger as compared to field in field. And it is also technically, it takes more time for the patient to get treated with IMRT. So in terms of doses to the contralateral breast and the treatment time, we usually go for field in field if there is no DIBH, field in field without DIBH. And if in field in field, the D mean of heart is not achievable, then we go for IMRT.
so? Arman, the answer is that for breast cancer, actually, if it is not RNI, still 3D with tangent is the best for whole breast. When there is a RNI, the challenge comes, and then we bring up the field in field forward IMRT, and better coverage we go for inverse planning. Gradually, we move from forward IMRT to VMAT, and nothing is free, as he was showing. When we are reducing the heart and lung dose, we are buying some risk of contralateral breast. So always, as a clinician, we need to make a call how to where to stop and how much you do when you are in an ideal world. But when you don't have everything, then again we need to find a way. But still, as he said, the field in field forward IMRT is still the more or less one of the best solution for all the situations, especially is RNI. So Sandeep, I have one question that you said there is a principle ICRU you follow for 95%, 95, 95 or 9500. So is it possible when we have the volume like PTV for breast, PTV IM node, PTV SCF, not XLR? This is a normal scenario. Physicists say, sir, if you want me to give 95 to IM, you need to accept some more toxicity to more dose to lung, or you need to accept 90% of IM. What is your comment on this? Is it possible always to cover all the PTV with the ICRU references by justifying the way of tools?
Sir, as per sir, I've shown in one of my slides the RTOG constraints that was given by Rudra et al., in which they had specifically said that PTV coverage for internal memory as well as SCF, it can go as low as 80% when giving. So I think, sir, if internal memory is being covered by 80% of the dose, keeping in mind that the doses to heart and lungs are being achieved, I think, sir, we should go forward with that. If there is a gross nodal internal memory lymph node, then that's a different matter. Then I think we'll need to give a boost, and then maybe we'll have to cross the dose constraint for heart.
Yep. So the answer is what he said, that for our colleagues, junior colleagues, that this is a universal law that 95% should get 95% dose. We will be looking for 95% PTB coverage. But if we stick to that, sometimes it is not possible. We need to make some compromise, say, I don't want a hard dose above 5. So then maybe I will take 90% of the iron node. Again, I look at the location of the tumor, what was the tumor burden, nodal burden, all these things. I mean, what is the age of the patient, what are the comorbidities? By this, we make a trade-off between the OAR dose, especially here, the hard dose is the issue. Sometimes lung dose is also issue. So these are guidelines, these are set rule, but this is not a Bible. We clinician must understand the strength and weakness of all these limitations, and then we should proceed. The next question is, Sandeep, if it's a reconstructed breast,
Yes, sir.
so it is a chest wall PMRT, but it is a whole breast.
Yes, sir.
I mean,
Yes, sir.
then for our student, how to evaluate? I mean, shall I take it as a whole breast or take it as the PMRT or something in between?
Sir, I think this question has been haunting us for quite some time, and I think it's still a gray area, and there are still trials going on whether to include the whole breast or not. But I think, sir, most of us radiation oncologists, we don't take the whole breast. We spare a little bit of skin. So I think at our institute, sir, we are cropping around 1 centimeter or maybe 1.5 centimeter from the skin, and then we'll including all the rest in the PTV.
So you are trying to create something between a whole breast and a PMRT in between.
Yes,
so
sir.
you are
Yes.
allowing some of the reconstructed breast to be spared. I mean, as you said, nobody knows it. I brought this issue intentionally because in our country, some of the centers are now experiencing this thing like reconstructed or breast implant, and now we are struggling that which way to follow. Shall we put it on the formula of whole breast or put it on the answer is we don't know. Many people have their own judgment. So this is what I said. It's quite reasonable that we can crop some area like 1 centimeter or something, or without cropping, when we evaluate, we can consider to allow our physicist colleague to have some cold area on the surface, because that surface we are considering it is not really breast tissue, it is a reconstructed issue. But somebody may argue the skin is there. Well, I mean, so there are, as he said, it is a gray zone. So the next question is, how much important is to draw and see the dose of LED, or mean hard dose is fair enough?
So it is important. I have stated some deGRO constraints that included the heart as well as left ventricle and left anterior descending. In our institute, sir, we are mostly following the D mean of heart, but in a patient who has had a cardiac event before, in such patients, we are taking constraint for a left anterior descending artery. We are giving a D mean of less than 10 in such patients, and we're trying to achieve that. But not for all patients, sir.
So your message is you are doing D mean, but in selected patient, when you think that you need to look into it, you can go for LED. It is good to see LED, but till now it is not a mandatory recommendation. Some of our colleagues is asking D mean. You said 6 to 8 in some, without DIBH. In your center, what is the maximum hard dose you accept without DIBH?
So in our institute, we have seen without DIBH, left-sided breast cancer, D mean goes around 8 or 9. It can also go to 10. So in such,
are we
yes,
not taking a big risk with 8, 10, because beyond 4, there is always a high risk?
Yes, sir. Yes, sir. So in such patients, we actually advise them to go through DIBH. If they are not able to, then we make an IMRT plan for them. And then with IMRT, the doses to heart, they reduce from 10 to around 5 or 6, around 6 Gray. So we achieve, I mean, we accept that, sir.
So you are telling that when with a conventional, you are getting a higher dose, you change the techniques to bring the dose down, because
Yes.
normally today in 2022, probably we are not going to take a 8-grade dose to mean dose to heart. What
Yes,
you
sir.
said, that comes when we do in conventional. So my another very funny question is, heart dose, will it be different for PMRT and whole breast, with or without RNI, or for everything it is the same principle?
Sir, what I've seen is overall it is the same principle, because the medial and lateral tangential, it will remain the same. In post mastectomy, I think the medial tangential is somewhat more towards the outside. It is not as with the breast. I mean, with the whole breast RT, the medial tangential, when including internal memory, I see most of this medial tangential going through the heart with the whole breast. But with post mastectomy, I think, sir, sir, in all the patients, we follow the DIBH. If a patient is not able to get DIBH, then we go for IMRT. And
Yeah.
with IMRT, sir, there is no problem with the tangential, and so.
Yeah, that's true. I mean, the point was coming that whether we are doing a post-mastectomy or whole breast, whether we're putting RNI or not, that is should not be the principle of our hard dose. Hard dose is hard dose. So our target is, say, if my institute, I don't accept above 4, it should be for all. It cannot be an excuse that as it is a PMRT, so I'm allowing more. No, because all heart is equally vulnerable, and normally we don't know the real dose. 3.3 was a cutoff. Somebody said, somebody says 4, somebody says 5, LRF principle. So for my junior colleagues, I'm telling that when we are using RNI or not, whole breast or PMRT, big chest, curved chest, hard dose is a hard dose. It is a weird dose. So we should try to achieve our target. And then the excuse of different organ, that whole breast, so we will do better, just mastectomy will not do better. It is not acceptable. Well, we need to make a call between the our coverage and the patient volume, the technique resource limitation. That is a different thing. So next question from Arman was that, is there any technique of drawing the volume when it is an oncoplastic breast surgery done? When you do whole breast, if it is that already we discussed. Probably there is no special technique. We draw the whole volume. During evaluation, we may be a bit considerate to allow some of the area where we think that the normal breast tissue is not there. So next question, why to use IMRT breast? Number 1, for less wear dose. Number 2, to avoid hotspot, or for cosmesis, better cosmesis, but dose homogeneity, or for all. And what is the objective in breast cancer?
Sir, the objective of using IMRT in breast, as I've seen in trials, which is by Barnett et al. And Fish et al., that doses to skin as well as doses to heart and lungs, they reduce substantially when compared to 3D CRT or field. And the PTV coverage is more homogeneous. So I think IMRT in breast is for all the reasons. To decrease the OAR dose to skin as well as lung and heart, and to avoid hotspot. I think, sir, it is applicable for all these points.
Yeah, you are very correct, Sandeep. I totally agree with you, especially when we are doing RNI, because still, if it is not an RNI, maybe we are not in need of inverse planning. We can go away with 2 nice wedges and forward IMRT. Without IMRT, there will be some hotspot. But once we go for a forward IMRT, we can get a homogeneous dose distribution, and then we can avoid the hotspot at the memory fold, and we can go away. So next question is, are you using APBI at your center? And for what indication? I mean, this is a very, I hear it much, but I don't see much people practicing it. I don't know why we discuss much and why we don't practice it. What is your comment?
Sir, it is a very tricky question. I know, sir, we have a guidelines, the ASTRO guidelines, which says that APBI can be used in certain individuals, but at our institute also, sir, we don't follow partial breast irradiation. We usually go for whole breast irradiation. The reason, maybe we are not confident enough yet to go for APBI. But yes, then again, it is, I think, being followed in the Western countries. It's still at infancy in our country, or maybe in the East also. So, sir, we follow whole breast irradiation only.
Thank you, Sandeep, for the honest comment that APBI may be something very good to discuss, a good question exam, very nice discussion. Unfortunately, in this part, I hardly see many centers practicing it. I mean, as you said, maybe we are not confident enough. We don't want to take a risk of partial breast irradiation and taking a chance of missing something, because the unfortunate part of the modern radiotherapy is majority of the failure happens in field recurrence. So in breast, we cannot allow that. So that's why probably we don't. So there's a question, a very interesting question, that in your center, are you using wing board or breastboard for breast cancer patient?
So we are using breastboard. We are using breastboard in our institute.
Okay.
And yes, sir.
So there was a statement in your slide, I copied it. D90 more than 90% also acceptable to meet homogeneity goal. What does it mean? Can you please explain for my junior colleagues that more D90 more than 90% also acceptable to meet the homogeneity goals?
So what I mean by that is, if the dose receiving 90% is by 90% the volume is 90% of the dose, if it is homogeneous, if there are no cold spots, no hot spots, and if it varies between 95 from not 90, but I think a few spots may include 90% of the dose, but most of it would should lie between 95 to 105. If it is less, so for slices, if we take a 3 mm slices, we usually go, if there is 2 or 3 mm slices showing a hot spot or cold spot, then we usually don't we don't follow that plan. And for 90% coverage, if it is 1 or 2 slices, then it is acceptable by us. But most of it should be between 95 to 105. Homogeneous, by homogeneous, I mean it should be between 95 to 105, sir.
So here, the main issue, what I wanted to bring up is a discussion what Sandeep said, that in breast cancer, we look at the coverage, what is the dose, what is the volume of coverage, and also we look at the dose homogeneity. Why these things moved from 3D to IMRT? First, it was not the, initially it was dose homogeneity, then the outcome came as a cosmesis, and that was the method how we justified IMRT, forward IMRT. And when the RNI, this IM node came in the field, then the all issues of inverse plan came. Before that, if somebody said that I do inverse plan, he was being challenged by many people. How come you do inverse planning in breast cancer? But this IM node and this targeted RNI has changed the whole world. Now people are even using VMAT. So my last question, if you treat all the 3 axillary level for some reason not adequate dissected, and the unfortunate lady need to have a supraclavicular field and also IM node, yes, what will be your selected technique for whole breast and PMRT?
Sir, in patients who have not complete lymph node dissection, axillary lymph node dissection, less than 10. So, sir, for if it is less than 10, I think we need to see, sir, as per MA20 protocol, if it is less than 10, then it need to be, it has to be with the, as per ASTRO guidelines in 2016, sir, if it is inadequate lymph node dissection, we should include regional lymph nodes, and it should include all the lymph nodes, axillary as well as internal memory and SCF.
Yep.
In our institute also, sir, we follow the same protocol.
So what technique? So, this is a special scenario. Normally, if we have a good axillary dissection, we don't cover 1, 2. We go only level 3 and in IM node. But here is an unfortunate lady. Unfortunately, the dissection was not adequately done. So we need to cover level 1, 2, 3, SCF, and also IM.
Yes, sir.
Whole breast, PMRT. What is your selection technique? Will you go for IMRT, VMAT, or inverse forward IMRT? What will be your technique?
So if the patient is able to do a DIBH, then fielding will be DIBH, sir.
Okay. If no DIBH?
If no DIBH, then IMRT, sir.
Inverse IMRT?
Inverse IMRT, sir. Yes, sir.
Not VMAT?
VMAT, sir, I'm not so much in favor of VMAT because of the dose to the convoluted breast that increases as compared to IMRT. And the RBR dose also is higher in the VMAT. The integral dose is higher. So I usually go for IMRT, sir.
Thank you, Sandeep. I totally go with you. In whole and breast, hardly I go for BMAT. I mean, I have seen in my experience that in BMAT, when we have a good coverage, the contractor breast and sometimes the lung dose, we cannot low dose lung coverage. 20% it doesn't matter. But when you look at a 5% dose,
5%. Yes, sir.
huge lung is
Huge.
irradiated.
Yes.
So for me, I mean, still I am quite happy with inverse IMRT. Maybe one day will come, I will go to VMAT. But some of my colleagues are fan of VMAT in breast, but personally not. So thank you very much. So
Thank you, sir.
I don't see any more question, and we are almost at the end of the session. So I am inviting all the colleagues to keep an eye on your. There is a raised hand by Tania. Any question from Tania? Are you going, Tania? If there is a question, you can put in the chat box, or Samia. Please keep an eye on your email inbox. Very soon you will get an email with the information of this course that we are going to start run with the collaboration with Bologna University of Italy. There will be 20 credit hour classes on radiobiology, basics of radiotherapy on different sites, and also some radiation physics and some research methodology of radiation. So it's a consolidated course on basic radiotherapy for refreshing, for new to see and old to refresh. So it is suitable for all, but the seats are limited. So first come, first serve will be the chance for registration. Everybody is requested to keep an eye and don't miss the chance, because we don't know whether we can repeat it, because our colleagues from Italy, they may not be able to give us time every time. But very soon from 21st June, probably we're going to start it. And within 24 hours, the mail will be in your inbox. So next week, we are going to our last session on breast cancer radiotherapy. It will be plan, check, treatment, delivery, verification, treatment, and follow-up. These are sounds to be very small thing, but these are very important. That how we really check these things and how we do the verification. It is, to me, it's very important, and follow-up. Everybody follow their own line, and what we do during follow-up. Shall I look the blood count, or shall I look at the clinical examination? These are something I found very important. So we will be talking on this. And Dr. Sarthak Tandon, a very brilliant person of Rajiv Gandhi. I know he is a breast guy there. So he will be talking. And thanks to our academic partner, Healthcare Pharmaceuticals, for supporting us on this endeavor. And definitely, why not Rajiv Gandhi? They have helped us by giving allowing all the faculties to share with us. So, I mean, with these few words, I think we have almost come to the end of the session. If nobody have any more comments, I think we can end today. Sir is there. Tanya, sir.
Yes, sir.
Sir, we can finish it, sir.
Please do that. We had a very nice afternoon today. The Purohit from Rajiv Gandhi. My thanks to Rajiv Gandhi Cancer Hospital and all the participants who took part today. Very nice discussion, very scientific, and very crucial discussion about the radiotherapy of breast. Thank you all very much. See you next time.
So thank you, sir. Breast is apparently a very easy thing, but not very easy. Easy things are always tough. And this is one of the main focus. 25% of our female cancer patients are breast cancer. So that is a huge coverage. And today we know by newer technique, RNA, we can give a better quality of life and better survival, not only quality. So we should give our best and with our knowledge. And thanks to our faculty, our participants, and the team behind working, and all the partners. And see you next week. Thanks to Sandeep again for sparing your holiday. And next week, see you all. Till then, stay safe. Thank you. Allah Hafiz.
Okay, bye-bye, everybody.